Let's start. So today we'll be talking about the vestibular neuritis and labyrinthitis. Okay. So basically, what happens is that a patient develops upper respiratory tract infection. Okay. Now, this upper respiratory tract infection through eustachian tube, it goes up into the air, and from air it spread to the inner ear. Now, inner ear, as you can see here, it has a cochlea and semicircular canals along with the vestibular cochlear nerve. So if the inflammation or the virus gets into the nerve, it will cause the inflammation of the nerve, which is called as vestibular neuritis. If if the virus gets into semicircular canal, okay, or labyrinth, okay, so what will they do? They will cause inflammation over there in the labyrinth, inflammation of the labyrinth, and after the inflammation, they can cause edema, okay, and there will be increased fluid pressure in the semicircular canals and labyrinth, so which will cause vertigo. Okay, this as a whole is called as labyrinthitis, inflammation of the labyrinth. So there are some similarities and there are only two differences. Okay, inflammation of the virus through the inflammation of the vestibulocochlear nerve through virus is called as vestibular neuritis, while the inflammation of the labyrinth, okay, is called as labyrinthitis. Now let's move further. Okay, so labyrinth, here I just wanted to tell you about the labyrinth. Labyrinth is having a membranous labyrinth, and membranous labyrinth also have the osseous membrane. So this is the osseous labyrinth part, and this the inner side is the membranous labyrinth. And inside the membranous labyrinth, endolymph is present, which is a fluid. Okay, and these are the three semicircular canals. Okay, this is the posterior semicircular, which is very important. Okay, so this is also a part of the labyrinth. Okay, and you can see here, this is a cochlear duct, this is a saccule, and this is utricle. This utricle is very important in benign positional vertigo. Okay, let's move further. Now let's read it out. Vestibular neuritis is inflammation of the vestibular nerve, which is called as vestibulocochlear nerve, 8th nerve, vestibular neuropathy. There will be three things: vertigo, vomiting, and viral upper respiratory tract infection. So treatment will be to relieve the symptom that will be consisting of prochlorperazine. Now labyrinthitis is inflammation of the vestibular nerve and labyrinth. Okay, mostly the labyrinth. And both have the attacks of vertigo, nausea, and vomiting. They are aggravated by moving the head, and both are preceded by the upper respiratory tract infection, runny nose, cough, and fever. However, vestibular neuritis, here is the big difference. Okay, here is the difference between them. How are you going to differentiate between the vestibular neuritis and labyrinthitis? So vestibular neuritis does not have the hearing loss or tinnitus. So while labyrinthitis has sensory neural hearing loss plus tinnitus. So what happens is that this vestibular neuritis, they don't have sensory neural hearing loss, plus they don't have tinnitus, which is the ringing of ear. So you have only two things to differentiate it from the labyrinthitis. And in labyrinthitis, okay, they all have the other features, plus they have sensory neural hearing loss, plus minus they have tinnitus. This is the big difference you have to remember. So whenever they tells you that the patient comes after upper respiratory tract infection, okay, and now he is having vertigo, okay, because both of them can have vertigo. and and he is having a nausea, he is having nausea or vomiting, okay. Now still you are not sure. Now you have reached the diagnosis of vestibular neuritis as well as labyrinthitis, but still you are not sure which one of them is it. So is it vestibular neuritis or labyrinthitis? In the next paragraph, they might have given that this patient has come up with sensory neural hearing loss. Then you will click labyrinthitis. If they tell you that they have tinnitus, then you might click the labyrinthitis. So you will go to the labyrinth. Okay. Now, if they tell you that the patient doesn't have sensory neural hearing loss and doesn't have tinnitus, then you will go and click the vestibular neuritis. I hope it's clear now. They all are preceded by the upper respiratory tract infection. So the scenario will start with upper respiratory tract infection, and it will go towards the vertigo, nausea, vomiting. So at the last, there are two differences between them. One is the sensory neural hearing loss, which is present in labyrinthitis and tinnitus also, and there is no, big no, okay, to vestibular neuritis. Now let's move further. In summary, viral upper respiratory tract infection followed by the attacks of vertigo plus minus nystagmus vomiting is greater than vestibular neuritis. Not greater, sorry, it is equal to, okay. It means that we are dealing with vestibular neuritis. Why? Because there is no mentioning of sensory neural hearing loss plus tinnitus. So when they are absent, so you have got to deal with vestibular neuritis. Now, what should we use? We should use prochlorperazine, okay, to relieve the attacks of vertigo and vomiting. Okay. Now, viral upper respiratory tract followed by the vertigo plus hearing loss tinnitus is equal to labyrinthitis. Why? Because here you can see tinnitus and here you can see hearing loss, which is sensory neural hearing loss. Plus, the most important is viral upper respiratory tract infection. So you have got the answer. The next one is vestibular neuritis that take last hours or days, whereas benign proximal positional vertigo lasts for a few minutes. Now, this difference is very important. Okay, you must remember that it lasts for seconds or few minutes. Okay, few minutes. And this one, neuritis one, is for hours to days. Okay, this is much longer, but this is a very short period. I will explain this as well. But you just remember now that the neuritis, because it is the virus, okay, getting into the nerve. So when the virus get into the 8th cranial nerve, vestibulocochlear nerve, it will take some time to get out of the inflammation, okay, or to get relief from the inflammation. So it will take some time, okay, because it is dealing with the neurons. So it will take from hours to days. Now, common signs and symptoms of vestibular neuritis and labyrinthitis. Now, what happens is sudden onset of vertigo, and this is sudden, okay, in nausea approximately 1 to 4 days in both. Triggered by viral or bacterial infection. I told you upper respiratory tract infection present in both. Hearing loss or reduction on one side. Okay, this is vestibular neuritis, okay, on one side. And labyrinthitis, you see that you have, there is no hearing loss, no sensory neural hearing loss, but there is hearing loss present, sensory neural hearing loss present in labyrinthitis, okay. Now, dizziness and imbalance for weeks to months, it is present here as well as here, because they both are because of upper respiratory tract infection, and is basically inflammation. Now, frequent recurrence of the vertigo attacks uh, not present in birth, okay? Not recurrence. It just heals itself in 1 to 4 days, okay? It's not recurrent. And one more thing you can add is tinnitus. Tinnitus is present in uh, labyrinth, and tinnitus is not present in vestibular neuritis, as I told you, okay? Now let's move further. Now, injury to ear pinna with intact tympanic membrane, no further investigation, self-limiting. If hematoma, refer to ENT. If painful, give analgesics. I have already explained this. Okay. So here you have to remember to refer it to ENT whenever you see a hematoma. Okay, because the ENT specialist knows better how to deal with the hematoma. Hematoma presents tympanic membrane rupture. So in case of tympanic membrane rupture, you have to refer him to the ENT specialist. Now let's move on to otitis media with effusion, blue air secretory otitis media. The presence of the non-purulent fluid in the middle air occurring in the absence of acute inflammation. It may vary from thin serous fluid to thick viscous. Okay, so you might see different patterns of otitis media with effusion. Okay, it might be effusion which is full of fluid. You can see here the effusion is covering all the layers of the tympanic membrane, okay, or the pars flaccida. And here you can see there are some bubbles, okay, and there is some fluid. So you can see air fluid levels, okay. Now this is a normal air. Now what is glue air? Glue air is a condition where the middle air membrane fills up with fluids, okay, with fluid that can be thick and glue-like. With fluids that can be thick and glue-like. Okay, here you can see. Now this is a glue air. Okay, glue air is same. Glue air is when the middle air membrane fills up with a fluid that can be thick and glue. Now this is a thick and glue-like fluid. Okay. Now what we do is we insert a grommet. Okay. What is a grommet? Grommet is basically a window, short window, which is created in the in the tympanic membrane to relieve all the pressure of the effusion that is present in the middle air. So from middle air, all will come out through this window, and it will be secreted out. So these are the otitis media effusion, which is secreted out from the grommet. Okay, this is done for, as a surgical procedure. Now, otitis media with effusion or blue air. Now, eustachian tube dysfunction. It is the commonest cause of the conductive hearing loss in children. Commonest cause, okay? Otitis media. Patient will present to you that he doesn't hear, like child raises the TV volume up, or the child is doing poorly in school. So you must, because there will be no pain, okay? There will be no pain. So the patient might not know that he is having this problem. It is commonest cause, okay, and it is conductive hearing deafness. Why? Because you see that air cannot pass. Why? Because there is a blockage through fluid in the middle ear. Now, positive plus minus history of recurrent otitis media or upper respiratory tract infection or size adenitis. What happens is their adenites may be enlarged, okay. So when their adenites are getting enlarged, so this is air, okay, this is a middle ear, this is external ear, so they can clog up the eustachian tube. When eustachian tube is blocked, so the secretions cannot get out of the middle ear, okay. So these are adenites when they are oversized adenites, or they are having some recurrent or upper respiratory tract infections. The next one is tympanic membrane is either restructured, more common, or bulgy. Okay, so there is negative pressure created mostly in the otitis media with effusion. Okay, and in acute suppurative otitis media, there is bulging of the membrane. Okay, I will tell the difference. It might be bluish, gray, dull, or yellow. Okay, this is very important. So what we have to remember is the tympanic membrane will be gray, grayish, bluish, bluish gray, or gray bluish, or dull, or yellow. These all can be given as a clinical findings in Plab questions, and plus minus in air fluid level. There may be or may not be air fluid level, okay? Or they can give you a picture as well. So patient presents usually with hearing loss, which is conductive. Common examples are a child raising the TV volume up, a child is doing poorly in school, and a child lacks concentration and is socially withdrawn. Referred for audiogram. Audiogram will show conductive hearing loss, more commonly bilateral. This is more commonly bilateral because most of the disease which you are dealing with are symmetrical on both sides of the eustachian tube will be blocked. So treatment will be the first visit or recently diagnosed with otitis media with effusion, reassurance, and review in 3 months. Remember, so you always have to try the reassurance first. So the patient will come with otitis media with effusion. You should not treat him, okay? You tell him that it will resolve spontaneously. You just reassure him and tell him to come back in 3 months. In 3 months, okay? After 3 months, if he did not get his condition resolved, then you will go and proceed with the grommet insertion, okay? So what you will do is you will insert a grommet, which is a window that will allow the fluid from the middle ear to secrete out of the ear, okay? But that is the next step. After 3 months, if he still persists, then you will go for grommet insertion. Here you can see. If surgery is contraindicated or rejected, then you will go for ear aids, okay, which will enhance the conductive deafness, which will enhance the hearing in condition like conductive hearing. Always encourage the parents to stop smoking. Okay, so most probably smoking is a biggest risk factor in these children. So their parents are smoking, okay. Due to that, the patient can get glue ear or otitis media with effusion. Okay. Now, thus sometimes the answer would be advise parents to quit smoking. So you will see. So advice, or either it may be quit smoking, or either it may be reassurance, a review in 3 months, and the next, or either it could be that after 3 months, if it is not resolved, then you will go for grommet insertion. So these are the treatment plan in the otitis media with effusion. So many questions comes, so that's why I'm repeating again. And what would be the clinical features? They will tell you that, okay, a patient has come and his tympanic membrane is gray, bluish, or dull, or yellow, and there might or may not be air fluid level in the tympanic membrane, which I showed here. Okay. Okay, let's move further. Now, what is the advice that is stop smoking? Now, thus sometimes the answer would be if to advise parents to quit smoking, the parent smoking is a risk factor for otitis media effusion. So encourage them to stop smoking. Remember that otosclerosis is the commonest cause of progressive conducting loss in the young adults. I will tell you about the otosclerosis, but you just remember here that it is a progressive conductive hearing loss. Slowly, and gradually, your conductive hearing loss will increase, okay? And it is also present in young adults. Now let's move further. Otoscopy findings in some ear condition, okay? The first one is bluish gray yellow tympanic membrane with air fluid level. Obviously they are talking about the otitis media with effusion, okay? Bluish gray yellow or yellow, or okay, tympanic membrane with air fluid level. You know that you are dealing with some fluid behind the tympanic membrane. So what your answer should be? Your answer should be otitis media with effusion. Okay, otitis media with effusion. The next one is Schwartz. flamingo pink sign, that is tympanic membrane, and this is called as Schwartz sign. This is called as Schwartz sign. So what is Schwartz sign? Actually, okay, let me tell you briefly about the otosclerosis first. Now, this is otosclerosis, then we'll come back to it. Okay, I will explain these as well. First, let me tell you about the. Okay, the next one is inflamed tympanic membrane with the cartwheel appearance of the vessel. Cartwheel appearance of the vessel is acute suppurative otitis media. Now, what is cartwheel appearance? Here you can see is the cartwheel appearance. First of all, what you can appreciate is that you can see multiple, like cartwheel. Cartwheel is basically a wheel like this, and it is why, because these are the minor vessels which are being appreciable. Why? Because there is a pressure inside the middle ear, and that pressure in the middle ear is pushing the tympanic membrane outside, and that pushing of the tympanic membrane is helping and enhancing the minor capillaries in the tympanic membrane, so they are visible. So they present, and they can be perceived as cartwheel appearance. Okay, so wherever you see a cartwheel appearance, you can see here it is a pink tympanic membrane with cartwheel appearance. So you directly go for the acute otitis media, okay, or acute suppurative rather. Why? Because there is a pus inside the middle ear. When there is a pus inside the middle ear and it is acutely generated, the patient might be having pain, okay, and it is sudden. So this pus is pushing the tympanic membrane, and that's why tympanic membrane capillaries are shown, and it presents as a cartwheel appearance. Cartwheel, okay. So where were air fluid level present? Air fluid level were present in otitis media with effusion, okay, but cartwheel appearance is present in acute suppurative otitis media, okay. Now there is a family history. 50% is genetic and bilateral, and 80% mostly they are bilateral, okay. Now other symptoms would include tinnitus and vertigo. Tinnitus plus vertigo, okay. There will be ringing of ear plus the patient will present as vertigo. Why? Because these infection can proceed and go into the inner ear as well, okay. So they might be present more in females, so females are more prone to this acute suppurative otitis media. There will be conductive hearing loss. Why? Because I told you that this is tympanic membrane and there will be pus present here. So air could not escape the pus, cannot move away from the, cannot move through the pus. So there will be conductive hearing loss. So bone conduction will be greater than air conduction. Now, pregnancy accelerates the progression of the otosclerosis. Okay. So what else can you say? So mostly, okay, this is, they are talking about the otosclerosis. Okay, I will tell the otosclerosis now. No curative treatment. What you have to do is management is stapedectomy or prosthesis insertion. So okay, let me briefly tell you what otosclerosis is. Okay. Okay, so what happens is that this is a this is air pinna. This is air pinna. Okay, and this is tympanic membrane. This is the middle ear. Okay, this is middle ear, and this is the inner ear. So what is here? So there are basically three bones, as you see. So there is one stapes, okay, and there will be malleus, and there will be incus, and this one, the last one, is stapes. Okay, so malleus, incus, and stapes. Okay, what happens is that the patient with otosclerosis, okay, because of their family history or genetic predisposition, okay, because they are genetically having abnormal gene for otosclerosis, what happens is these patient develops some bony tissues, okay. Now they will develop some bony tissues over here and around the stapes. Then stapes, what happens is the stapes doesn't vibrate sufficiently. Whenever the air comes and vibration comes here, okay, it can pass through the malleus incus, but the stapes cannot vibrate sufficiently, and because this cannot vibrate sufficiently, so it cannot further further uh, transfer this vibration properly, so the patient will be unable to hear properly, okay. So mostly so this will increase, okay, there will be progressive otosclerosis, and at last they won't be able to hear, okay. So this is called as otosclerosis, okay. Basically their ear auto becomes sclerosed with bony tissues, okay. And you can see, or you can appreciate the tympanic membrane. There will be whitish stuff along the tympanic membrane, and there will be some bony growth over here. So then you will be able to find out that this patient is having otosclerosis. Now the first thing is family history, which is most important, okay. The second thing is measles, okay. The patient who are having measles or recovering from measles, okay, they might have this problem. And the third thing is fracture from the ear ossicle. Some fracture of the ear ossicle can lead to this otosclerosis. And lastly, pregnancy. Pregnant women, okay, somehow they develop otosclerosis. They are on the verge of, and they have a risk of otosclerosis. Now let's see what we have got in otosclerosis, okay. Now I told you that we are having flamingo or pink blush tympanic membrane or Schwartz sign in otosclerosis, okay. Now what is this sign, okay? So basically what happens is that there is a pink, so this is a tympanic membrane, okay. So because there is otosclerosis going on inside the middle ear, okay, so this is the middle ear, okay. So from here, from the tympanic membrane, you will see some red area, okay, or inflamed area, or some hyperemia, okay, anything you can call it. So what is this? So otosclerosis in stapes here, otosclerosis in stapes leads to hyperemia of the promontory, okay. So there is a promontory. So in the promontory, promontory is visible through the tympanic membrane. So that red hyperemia will tell you that there is otosclerosis going on in the stapes, okay. So this sign is called as Schwartz sign or flamingo pink blush. So whenever you see a flamingo pink blush or Schwartz sign, flamingo is, I think, a bird whose head is red, okay, but his feathers are white color, okay. It is a sea creature, sea bird. So same as the bird, there will be a redness in the middle, okay, and the next area will be normal. So there will be hyperemia in the middle, and that will show actually the otosclerosis in the stapes, okay. That will lead to the hyperemia in the promontory. So that will be visible through the tympanic membrane. So wherever you see flamingo pink blush or Schwartz sign, you directly say that okay, so we are dealing with otosclerosis, okay. The patient might be young, from 15 to 45 years old. Now let's see the difference. Okay, now air fluid level. So whenever you see air fluid level, you say that okay, we are dealing with otitis media with effusion. Okay, here you can see the level. Okay, you can see the line. So fluid is below and the air is above. This is called as air fluid level. It describes the obstruction. Okay, and here also you can see. Okay, and now this is Schwartz sign. Okay, here you can see this we are dealing with the Schwartz sign. This is basically the pars flaccida. Okay, and this is the pars tensa. Okay, and this is the umbu. Okay. Now you can see the Schwartz sign. There will be some hyperemia here. Okay, and flamingo red. And what is this cartwheel appearance? This we are dealing with acute suppurative otitis media. Okay. And here you can see it is bluish, kind of a gray, bluish, or dull. Okay, or it is not that much bulging. This is called as bulging. Okay, I hope it's clear now. Now let's move further. So yes, last thing is, what is the management? So there is no curative management. What is the last procedure? The last procedure is, what you can do is you do a procedure. Okay, that procedure is called as stapedectomy. Okay, so what you will do is you will insert a stapes, a new stapes bone. So suppose this is inner ear and this is middle ear. Now here was stapes, okay, which is not basically present. Okay, what you will do is, there was some otosclerosis here. You will remove this stapes. You will remove this stapes. Okay, this is incus. Okay, this is incus, and we have removed the stapes. Okay, and this is the inner ear. This is the middle ear. Now what we do is we insert something like this. Okay. So whenever it will perceive the vibration, it can convey it further. Okay, this is called a stapedectomy. Okay, now let's move further. So what you will observe on the tympanosclerosis, there will be tympanosclerosis. This means that on the tympanic membrane you can see sclerosis. Sclerosis can be seen as a white stuff. Now there will be conductive hearing loss. Look for chalky white patches over the eardrum. There will be white patches and chalky over the eardrum. Okay. Okay, now let's move towards the cholesteatoma. Okay. Now what is cholesteatoma? Okay, I will briefly tell you about the cholesteatoma. So basically, cholesteatoma are of two types. One is called as congenital. Okay, the other one is called as acquired. So in acquired, there are two types. One is called as primary, and the other one is called as secondary. Congenital, how you will say, what is the congenital? So congenital don't have, there is no tympanic membrane rupture or no perforation. There is no tympanic membrane perforation. Remember, no. In primary, there is also no rupture of tympanic membrane. No rupture of tympanic membrane. That's why it is called as primary. How can we differentiate it from the congenital? Because it is present in the childhood, but this might be present in the adulthood. Okay, so this is called as primary. Why? Because there is no tympanic membrane perforation. And what about the acquired one? Acquired secondary. So the secondary one is when you have tympanic membrane perforation. When you have tympanic membrane perforation. Now, let me briefly tell you about the primary. Okay. So what happens is, this is a middle ear. This is inner ear. And this is the outer ear. So these cells, which are called as keratinizing, the whole topic will be based on this kind of epithelium, okay, on this thing, keratinizing squamous epithelium. Okay, the whole topic is about this keratinizing squamous epithelium. It is not a tumor, it is not a cholesterol, it is just a bunch of cells. And what kind of cell? Keratinizing squamous epithelium. Okay, now in the middle ear there is no presence of keratinizing squamous epithelium. Now the scientists were shocked that how when this keratinizing squamous epithelium is not present in the middle ear, how come the keratinizing epithelium is present here, okay, without the rupture of tympanic membrane in congenital as well as primary. Okay, so there they came up with some theories. They said, okay, so maybe because of the recurrent infection, okay, because of the recurrent infection, recurrent middle ear infection, because of the acute suppurative otitis media, or maybe because of the acute otitis media, or anyway, because of the recurrent infection, what has happened is that normally this there is a epithelium. Okay, so this epithelium, because of the recurrent infection, might have changed into the keratinizing squamous epithelium. I mean to say that there might have been a metaplasia of the normal cell into keratinizing squamous epithelium, okay, because of the recurrent infection. This is one theory, okay, and this keratinizing squamous epithelium is going to cause a cholesteatoma now, okay, without the rupture of tympanic membrane. So it could be primary or congenital. Now the next theory they come up with, the scientists come up with, was that, okay, because of the recurrent infection, there was hyperplasia in the middle ear. The hyperplasia, there was hyperplasia of this keratinized squamous epithelium in the middle ear, okay, without being rupturing the tympanic membrane, because it is mostly present outside in the outer ear. Okay, so they were shocked that how come this epithelium is present here over here without rupturing this? How did they come up here? So they came up with the idea that, okay, because of the recurrent infection, there might be hyperplasia of the keratinized squamous, or there might be metaplasia of the normal cell into keratinized squamous epithelium. Okay, so these were all about the primary congenital. Now, in the Plab, they are mostly concentrating on the secondary cholesteatoma. Okay, now we are going to explain the secondary one now. Now, what happens in the secondary one? Okay, secondary cholesteatoma. In secondary cholesteatoma, what happens is that there is tympanic membrane perforation. So this is middle ear, okay, and this is the outer ear. So from the outer ear, what happens is that keratinized squamous epithelium move and rupture the tympanic membrane, and it moves inside the middle ear. And in the middle ear, what they do is they convert into necrotizing otitis media, okay, and they perforate the tympanic membrane, and the epithelium or migrate into the tympanic membrane. Okay, so then, but the thing is, these are very notorious kind of cells. Okay, they are very destructive. Okay. What they will do is they will come and they will start eroding. They will start eroding the whole middle ear, and they will expand and destroy the whole structure which is present in front of them. Okay. And lastly, they will damage the ossicles. They will damage the ossicles. So basically, it's like a tsunami or something. Okay, whatever comes in its way, it can finish it off. Okay, so the whole tympanic membrane, the whole ossicles, and all it can damage. Okay, and it is irreversible. So what you will have to do is you have to take it out via surgery. Okay, now let's read it out. So collection of the keratinized squamous epithelium in the middle ear that is able to expand, erode, and destroy the adjacent structures, causing tympanic membrane perforation and ossicle damage. It is neither a cholesterol nor a tumor. Pearly white mass. Look, pearly. This is a clincher of the cholesteatoma. Wherever you see a pearly, look here. Here you can see this is a pearly white mass, and it has ruptured. You can see it has ruptured the tympanic membrane. So we are dealing with a secondary cholesteatoma. Now, so this is a main clincher, pearly white mass behind white mass. This is a clincher behind the tympanic. Remember, the white chalky mass on the tympanic membrane is tympanosclerosis. That is white chalky mass. It is like a okay. So it is like a candidiasis of the tympanic membrane. Okay. You remember the candidiasis on the tongue. Now this is a candidiasis on the tympanic membrane, which can be called as tympanosclerosis. Okay, but this is different. This is a pearly white mass behind the tympanic membrane, and it is very pearly. It is not chalky mass spreading, not like cheese or spreading on the bread. Okay. So chronic foul smelling purulent discharge will be there. This is called otorrhea. Otoscopy may reveal air canals with pus, mucus granulation tissue. This is what is causing the destruction all over. So there will be history of recurrent otitis media. Okay. And so cholesteatoma is poorly responsive to antibiotics. It is very dangerous. It can cause conductive hearing loss. Why? Because I told you it will destroy all the air ossicles. In congenital cholesteatoma, look, here they come. The same, but the presenting child is between the 6 months and 5 years. So you have to remember this, okay? Whenever a patient comes with 6 months to 5 years, you are dealing with congenital. Usually there are neither history of recurrent otitis media nor tympanic. Here you can see the main clincher or the main thing, the main differentiating point in the congenital cholesteatoma is that there is no tympanic membrane rupture. Okay. Now, because of the ability of the cholesteatoma to erode and damage the adjacent structures, the presenting symptoms may include facial paralysis, vertigo. Now, look, I told you whatever comes in its way, it can damage it. Okay, it can destroy it. So if it goes towards the facial nerve, okay, it will destroy the facial nerve and leading to facial paralysis. Okay, if it had a chance to insert into the inner ear, it can lead to vertigo and headache and deafness and earache. Okay, whatever it is. So cholesteatoma, pearly white mass behind the tympanic membrane, you are dealing with cholesteatoma. Now what you are going to do is you are going to do a surgical removal of the cholesteatoma. I told you it's not a tumor. Okay, it's not a cholesterol. It is just a keratinizing squamous epithelium. Okay. Now we did a good topic. Now let's move towards the next topic, which is the acoustic neuroma. Okay. Now this is also very important. Okay, so acoustic neuroma. What is acoustic neuroma? It is basically a schwannoma. Okay. So what happens is in the brain. So there is a brain. Okay. In the brain, you might be having a schwannoma. Okay. Schwannoma is a tumor based on the Schwann cell. So it will be here. Okay. So it will, because there is a vestibulocochlear nerve coming from here. Okay. So this angle specifically is called a cerebellopontine angle. Okay. So from the cerebellopontine, so here is cerebellum. Okay. And below is pontine. So in the angle of between the cerebellum and pontine, this schwannoma develops. Okay, and this schwannoma enlarges. Here you can see. So here this is cerebellopontine angle. So here the schwannoma has enlarged, and look, it can compress the facial nerve. Okay, and it can compress the, which is 7th nerve, and it can compress the vestibulocochlear nerve, which is 8th nerve. Okay, and it can also damage the two other nerves, which are called as 5th and 6th nerve. 5th and 6th nerve. 5th is the trigeminal, and the 6th is the abducens nerve. So look, it will come up here. Okay, and it will involve the facial paralysis, the sensory neural hearing loss might be, or it can have some other problems like 5th and 6th nerve. So whenever you see 5th, 6th, 7th, 8th, you are dealing with vestibular neuroma. Okay, you are dealing with the vestibular schwannoma or acoustic neuroma or vestibular schwannoma. Both are same. Vestibular schwannoma or acoustic neuroma. You can see here the diagram. Okay, multiple diagram. Here you can see there is vestibular acoustic neuroma which has developed in cerebellopontine angle. Now it can increase in size, and because here are the vestibulocochlear nerve and facial nerve. Okay, so it can damage these nerves. Okay. So whenever you get the symptoms of damaging 5th, 6th, 7th, 8th nerve, so you are dealing with the acoustic neuroma. And one more thing is important: whenever a patient comes to you and you do the CT scan and all, and you see that you have got two neuromas on both sides bilaterally, then you must be dealing with. What was the thing? Okay, it will come neurofibromatosis 2 years, which is dominant condition. Okay, so what is acoustic neuroma? It is there will be pressure effect on the cranial nerves. Look, the main point is the pressure on the cranial vestibulocochlear nerve, which is 8th, and so because of the compression of the vestibulocochlear nerve, you will develop these signs, DVT. One more thing, I told you that whenever DVT is present, so you will consider the patient is having mania disease. Okay, the patient is having mania disease. But if the patient is having DVT, plus any nerve compression, like 6th, 7th, 8th, or 5th, okay, any nerve compression, then you are dealing with the acoustic neuroma. So DVT is very much the only symptoms which is present in mania disease. But when DVT comes along with the nerve compression, then you are dealing with the vestibular schwannoma. Now look, DVT, deafness, vertigo, and tinnitus. So facial nerve, cranial nerve 7 palsy, facial drooping will be there. Abducens nerve is involved, diplopia of the same side. Now you can see whenever you see that you are having some symptoms which are beyond the ear, so then you are dealing with the acoustic neuroma or schwannoma. Why? Because look, vestibular nerve is is responsible for deafness, vertigo, tinnitus. Facial nerve is supplying the facial, so there will be facial palsy as well, and there will be abducens nerve which supplies the lateral rectus of the eye, so there will be diplopia of the same side. Okay, so there are symptoms which are beyond the ear, so then you are dealing with acoustic neuroma. DVT, only mania disease. If only DVT is present, then mania disease. If any nerve compression along with DVT is present, then you are dealing with acoustic neuroma. And I told you the position of it. Okay, and yes, one more thing, I told you if a patient comes to you and he has so this is cerebellum and this is pontine. Okay, so if he has acoustic neuroma present on the both side of the cerebellopontine angle and it has enlarging, so you must be dealing with you must be dealing with neurofibromatosis type 2, okay, which is an autosomal dominant condition. Now let's read it out. So there will be trigeminal fifth nerve involvement, loss of the corneal reflex and facial sensation, intracranial pressure manifestation. There will be headache and space occupying lesion. Feeling of fullness in the affected ear. Important will be feeling of fullness or pressure in the ear is more classic sign of Meniere disease. I told you, DVT. Okay. However, if there is another cranial involvement like diplopia, okay, like sixth nerve or seventh nerve or facial sensation loss, okay, like diagnosis will be acoustic neuroma despite having pressure sensation. Now, what will be diagnosing? Diagnosis will be on MRI of the cerebropontine angle or MRI of the internal auditory nucleus. So everywhere you see investigation will be MRI, nothing else. The next one is DVT, deafness, vertigo, tinnitus, heaviness, pressure, in fullness in the ear. It is Meniere's. Whenever you see a DVT plus any cranial nerve palsy, then it is acoustic neuroma. Remember that MRI in the Meniere disease is normal, so there will be bilateral acoustic neuromas seen in the neurofibromatosis type 2. So you see there is bilateral acoustic neuromas. So whenever you see bilateral neuromas, you can suspect neurofibromatosis type 2. Okay. Okay, so that will be all because the time is finished. Thank you.
Thank you very much.
Welcome.